Good afternoon, dear colleagues. I'm Dr. Khaled Reyad, Professor of Plastic Surgery. Today we're talking about congenital hand anomalies. Probably you've seen some. Um, our objectives today is to classify the congenital anomalies and have clear vision about the relation between the timing of interruption of embryologic process or embryologic development and the resultant phenotype or the resultant change in the skeletal or soft tissue. We have two classifications, the Oberg-Manske-Tonkin classification, and this discusses mainly the embryologic and the timing, while Swanson or the International Federation Society of Hand Surgery, it discusses both the timing and phenotype, but mainly the phenotype. What do we mean by phenotype? Phenotype is the skeletal or the physical change in the hand or upper limb. We will explain the embryology and mention that some embryological data will recognize the features of diseases, our plan and timing. To determine the extent of the problem, we should know that congenital hand anomalies occur in one in 500 or 600 live births, and this is a very large percentage. About 10% or less than 10% are anomalous associated with syndromes in other parts of the body, and has a higher incidence in males. To know its etiology, it's mainly genetic mutations or chromosomal disorders. Sometimes it's environmental or teratogenic things like thalidomide. We also mentioned thalidomide. It is still a drug used for immune modulation diseases like MS, maternal diabetes, and amniotic disruption. Sporadic or multifactorial genes plus extrinsic or environmental interruptions or environmental factors, and vascular disruption in utero as subclavian artery disruption. Subclavian artery disruption may cause upper limb abnormalities. The embryology of limb development. We have three signaling center. What is meant by signaling center? Signaling center is as small ships that guide large ships in small canals. The small ships are the apical ectodermal ridge, which determines the proximal to distal configuration. Think it's like big ships guided by smaller ships. Okay, the apical ectodermal ridge, and this may find questions, multiple choice questions, ask about these relations. The zone of polarizing activity, it guides antero-posterior, like radial to ulnar or thumb to small, and the dorsal ectodermal, sometimes it's called ridge, it guides from palm to dorsum. Zone of polarizing agent from radial to ulnar, it guides from radial to ulnar. Underneath these, there's zone of proliferation and the mesenchymal differentiation zone. Very important thing to know that the digital rays, or the limb bud first, the limb buds appear on 26th to 28th day, and the digital rays, the fingers and metacarpals, appear from 6 weeks, and the interdigital apoptosis occurs by week 8. What's meant by interdigital apoptosis? As we may know that fingers are created like duck fingers with webbing. So these webs start to undergo apoptosis on week 8. So what we were saying that the disruption timing predicts phenotype. What's meant by this that the timing or the day or the week that occurs the external or the gene mutation or whatever happens determines the change in skeletal and upper limb. That's to say, in early weeks, if the insult occurs, it may lead to transverse arrest of the development. But later on, it may involve differentiation. We are coming now to the classification to make it more obvious. Actually, I have two classifications. Swanson classification, or the International Federation of Hand Surgery. It describes the phenotype classification. We differentiate into failure of formation and failure of differentiation, duplication, overgrowth, undergrowth, constriction, bend syndrome, and generalized skeletal abnormalities. We're coming later on in details. The Oberg-Manske-Tonkin classification, it divides the congenital anomalies to three large categories. Malformations, which as abnormal embryogenesis malformations, and the deformation, it was normal tissue and an external factor applies forces that changed this, and dysplasia, it's abnormal cells. This is a descriptive rather than a descriptive for phenotype. It is descriptive for timing and the embryologic deformity. So we mainly, you are a surgeon, so you more acquainted with the Swanson classification. Let's start with failure of formation. We mean that there is a part of the upper limb was not formed. This part may be in the upper arm, maybe elbow, maybe proximal forearm, maybe at any level starting from the shoulder joint up to the tip of the fingers. But it's most commonly in the proximal forearm. Sometimes there is nubbins over the distal part. It's mainly managed by prosthesis, either myoelectric or body powered, and surgeries only for neuromas or abnormal bone prominences that may need some shaving or something like this. This is transverse arrest, probably at the level of heads of metacarpal. It's the same part at the level of the heads of metacarpal. So it's more commonly in below the forearm, but it may occur at any level. Following this, we are still under the big classification under the failure of formation. Now we're going to the longitudinal or the preaxial. As a general knowledge, preaxial is radial and postaxial is ulnar. We will discuss radial longitudinal deficiency. The deficiency here is in the radius and the radial structures. Okay, we have two classifications. The most common is Haeckel classification. Type 1, there is mild hypoplasia with a slight deviation to the radial side. And as we progress from second to third to fourth, up to complete absence of radius. And with progression, the angulation is more and the bowing of the ulna is more. Very important notice that this deformity has very high association with syndromic associations like TAR syndrome. TAR refers to thrombocytopenia and absent radius. Fanconi anemia, which is pancytopenia and request a test called chromosomal breakage test. Holt-Oram syndrome associated with cardiac septal defects. And Vacteryl association. Vacteryl is every letter stands for deformity. V is vertebral column, A anal atresia, cardiac, TE is tracheoesophageal fistula, R renal, L limb deformity. We treat the radial deficiency according to the degree and according to the timing. First, the degree is very like first or second degree preoperative splinting. The splinting aims to stretch and decrease the contracture of joint and ligaments around, but not to lengthen the bone. More degrees like second, third, fourth may need to do centralization, that is medial mobilization of the rest of the distal part of the radius over the rest joint. Okay, this reposition makes the radius central. Plus soft tissue balancing, we may release of tight radial structures and tendon transfers and tightening of tendons. Thumb reconstruction, if the thumb is not there, we may do thumb reconstruction. Sometimes we do distraction osteogenesis or wedge excision to stabilize the ulna or the remaining ulna. Okay, so the very important thing in radial deficiency is it is associated with syndromes, and its treatment may be like not in our specialty, especially we don't deal with radius or we don't deal with carpal bones, but as a general you should know even the names of the operations. The same for ulna, but ulnar longitudinal deficiency is far less common, and also the problem is not in the rest mainly. Why? The articulation between the ulna and the rest is very small, but the main articulation is with the radius bone. But the articulation in the elbow joint is mainly with the ulna. So the problem will be in the elbow joint. We will find that there is sometimes absent joint or fused bone. And according to the classification, you will find the deformity. The management is has the same idea like radial forearm, but the common association for or with it like syndromes, associated with syndromes. Okay. Now we finished the lack of formation, and we are going to discuss failure of differentiation. As we talked before, the timing of the interruption of the embryologic process determines the type and the degree of deformity. Failure of differentiation occurs later on. The most common form is syndactyly. Syndactyly means abnormal fusion of or congenital fusion of the fingers. Okay, we can describe it according to the continuity of the webbing, if it's complete or it's incomplete. The incomplete is definitely not extending to the fingertip. Either it is simple or complex. The simple is soft tissue only, but the complex involves bone. Complicated like in complex syndactyly and associated abnormal joints and things like this, it's complicated. One important thing that you should know, that the most common, this is for MCQ questions, the most common site is the third web. It occurs bilaterally in 50%. It is linked to autosomal dominant genes. The second thing is that it is associated sometimes with syndromes like Apert syndrome. Apert syndrome is called acrocephalic syndactyly or acrocephalic. Acro means distal. Syndactyly fusion, distal fusion of fingers. Sometimes you find small part not fused in the proximal web, and this is rare. But you find Apert syndrome, you may find different shapes of the hand like spade hand or rosebud hand. The treatment is very complex and involves many stages. Poland syndrome. Poland syndrome is associated with syndactyly and most commonly brachysyndactyly, short fused fingers, brachysyndactyly, with association of abnormal breast, abnormal skin, subcutaneous tissue, abnormal muscle. Pec major may be absent or may be deficient. Ribs may be absent and even sometimes associated with abnormal thoracic shapes. Okay, Poland syndrome is important to know because it involves hand and aesthetic surgery in patients with Poland or females with Poland syndrome. You need to reconstruct the breast. How to manage syndactyly timing is very important. We divide the syndactyly, either simple or complete, into border digits. The border digits are the first and fourth ribs. These should be managed very early. Why? Because differential growth may lead to deviation of the fingers. Differential growth may lead to deviation of the fingers. So we may operate upon by 6 to 12 months to prevent angulation. Otherwise, or the other fingers like middle finger, index and ring fingers, like second or third ribs, may be done at 6 or later on at 12 to 18 months. Okay, very important notice not to make incisions surrounding one fingers. For example, if you have the second and third ribs fused or syndactylized, never attempt to release the second and thirds in the same time because you may jeopardize the blood supply of the dorsum, not arterial, the venous, and may lead to congestion of the whole skin. Okay, division is easy and you may even did one or two cases. It's like double or we call it mirror image, zigzag incisions or Cronin incisions. Very important thing is to reconstruct the web with a flap, not a graft. With a flap, the flap just dives into the web and reconstructs this area because the web creeping may cause fusion of the fingers again. So you must release with a flap. The flap is taken from the dorsum of the fused fingers as a rectangular, triangular, or hourglass flaps. You may put also skin grafts if you are a lack of tissues or even wrong decisions, wrong marking. Sometimes you find that the flaps you did is not coapting together. Don't do it under tension. Never do it under tension. Release and put grafts. Complex and bony syndactyly require careful separation and monitoring or dissection of the bundles. Sometimes you have one bundle for 2 fingers or 3 fingers. It's like in Apert syndrome, you have one bundle sharing in 2.5 fingers, so you or 1.5 finger. So you must dissect and know where's the bundle before you start dissection. Also, in the failure of differentiation, there are 2 deformities that always we have misunderstanding between them: the camptodactyly and the clinodactyly. Camptodactyly more means flexion. And knee involvement, it's called arthrogryposis and not camptodactyly. The other deformity is clinodactyly. Clinodactyly is abnormal deviation of the finger, otherwise it's away from its axis. I mean radial and ulnar deviation. The common cause is trapezoidal or delta epiphysis, or the bone itself has a normal shape that favors medial or lateral deviation. Most commonly, it occurs also in the little finger and it's associated with Down syndrome. Its treatment, splinting, if it's not, and most probably it not work, we do closing, which we excise a triangle and fix the remaining bone to make it straight. Again, to the general classification system, and now we start duplication. Duplication mainly may be preaxial, and this is the most common. Preaxial I told you before, it's radial side, or postaxial to the ulnar side, and central. The postaxial is the most common overall, but we mainly treat the preaxial. Why? The postaxial most probably appears like a rudimentary part of the little finger that usually parents do like a thread and cut this part, or do they go to someone to cut it. But as surgeon, you deal mainly with the preaxial or the central. The preaxial or thumb duplication, central may occur as a mirror hand. You may find the patient with 8 fingers. Okay, there is a classification for preaxial or the thumb duplication. It's Wassel classification. Wassel classification is very simple. You just duplicate from distal to proximal. Grade 1 is the distal phalanx. Grade 2 is the DIP. Grade 3 is the proximal phalanx. Grade 4 is the MP joint. Grade 5 metacarpal. Grade 6 up to the basal joint. Grade 7 is triphalangeal thumb. Okay. Very important to know about how to deal with thumb duplication. Thumb duplication, you may deal if there is a predominant finger and another finger with no function. It's very easily to simple excision and joint reconstruction. It's very important if the polydactyly is grade 2 or more. It involves joints, so joint must be reconstructed, especially the collaterals, to avoid ligament or joint laxity. Some guy made an operation. Okay, this is this is simple excision and reconstruction of the joint. Another guy called Cloquet, he did an operation to excise the middle part or the inner part of both fingers, of both duplicated fingers, and attach the outer parts. So he preserved the ligaments that are outside and make it in one finger. He gets the best parts of the fingers, of the 2 fingers, and sometimes he do wedge osteotomy to correct the proximal part, or the metacarpal. The timing, it's performed typically between 12 or 18 months, maybe later also. Postaxial polydactyly, it's common, especially in African descendants. It's associated with syndromes, especially trisomy 13. Okay, its management is more simple as it does not involve a very important finger at the thumb. Again, we are going to the classification system, Swanson classification system, and this is Overgrowth. Overgrowth, mainly defined as macrodactyly. Macrodactyly may involve a phalanx in the finger or the whole finger, a part of the hand. So macrodactyly is defined as enlargement of any part of the finger or even part of the hand or the whole hand. We may call it giant hand or whatever. Okay, it may be static, like it enlarged during the intrauterine life and later after birth, then stopped the static, and either progressive, it continues to grow. It's mainly associated with neurofibromatosis type 1. So these patients, you should search for cafe au lait patches for neural tumors and any association. The treatment is treatment of the deformity and functional restoration. The problem is that all layers or all tissue elements enlarge, so you need to either to debulk all the layers or just to amputate the finger. Again to the classification, undergrowth. Undergrowth, we may find any hypoplastic finger, but it's mainly in the thumb or the hypoplastic thumb. We have a very important classification called Blouth classification. We have too many classifications in this lecture. We have Swanson, we have Blouth, we have Wassel, we have Hickel. So just it's very important to know this classification, and especially for the MCQ questions. Blouth classification discusses the hypoplastic thumb. Grade 1 is minor generalized hypoplasia. Grade 2 is absence of thinner muscles with first space whipping and collateral ligament insufficiency. Grade 3 is added as grade 2 but with extrinsic and tendon abnormalities. You may find unstable carpometacarpal joint and remnants of head of metacarpal only. Grade 4, floating thumb. Grade 5, aplasia. The treatment is a ladder is to reconstruct what you have, and make it of utmost or the best function as we may do tendon transfer, we may do opponenplasty. It's called opponenplasty, not oponoplasty, opponenplasty. You may do first web deepening. Other than this, you may do reconstruction by index policization. What is index policization? We harvest the index finger as neurovascular element with its bone, with its tendons, with everything, and reorient the index to 90 degree over the axis of other fingers in the location of the thumb. And this depends if we have the carpometacarpal ligament or we don't have it. So it's very important to know finger policization. Symbrachydactyly. Symbrachydactyly is multiple involvement of multiple fingers in shortening and fusion. It may be in 2 or 3 or multiple digits, all the digits. Again to the classification system. Constriction band syndrome. This is a band that occurs during the intrauterine life. This band just encases or surrounds the upper limb, lower limb, whatever it surrounds, it causes deformity. It is divided into 4 degrees. Type 1, simple groove. Type 2, distal lymphedema with more grooving. Type 3, groove with distal fusion. Type 4, intrauterine amputation. Okay, there are 2 very important things to know about constriction band. The first is if the band causes edema and causes too much pressure, you must release even in the neonatal period. Neonatal period. And reserve the elective release for less than for constriction bands with less pressure. Okay. Again, the generalized skeletal abnormalities are mentioned for skeletal deformities that do not belong to any part of these earlier classifications. That's it, but there is very important things to take in your mind that we will walk one by one. The anomaly, the radial deficiency or radial club hand, it's associated with TAR, Fanconi, Holt Aram Vectoril. You must do CBC and platelet count immediately postnatal. Why? You shouldn't do it as a routine preoperative. It must diagnose if the patient has other congenital anomalies like these. Chromosomal breakage test, echogram, renal ultrasound. Complex syndactyly, like Apert and Poland syndrome, you must do craniofacial examination, chest examination. It's very important to mention in oral and MCQ exams. Central polydactyly, it's acrocephalosyndactyly spectrum, also for skeletal or genetic abnormalities. The postaxial, as we told, trisomy 13. We should do echo and retinal examination. Clinodactyly, associated with Down syndrome. Macrodactyly, we must examine for neurofibromatosis like Café-Olé patches or plexiform neurofibroma. The timing is important, as we talked before. Some may be managed as neonatal days as constriction bands with vascular compromise or even with severe edema. Okay. The other thing is later on, after 6 to 12 months, for differential growth as in syndactyly or in radial deficiency, radial club hand. Later on, after that, the other congenital anomalies. The take-home message is that, as we mentioned before, that the Swanson or IFSSH classification is clinically mainly, but the OMT mechanism or OMT classification is for mainly biology and embryologic description. Always screen for associated syndromes before surgical plan. Timing is anomaly specific, not generalized. Preserve function over cosmesis. Reconstruct stable, well vascularized, mobile parts rather than a purely normal one. It's also a multidisciplinary team involving plastic surgeons, genetic hand surgeons in orthopedics, and hand therapists. Good luck. Thank you.